Hey everybody, welcome. You know, when you hear the word link, you probably think cuff, you probably think...
Hi, sorry to interrupt. I just need to interject for a moment. Marc is about to talk about cross-linking, and some of you may know that he has covered this topic previously in his challenging patient dialogues with Andy Morgenstern, who was amazing, and also a certain male technician played by me. Anyway, humor him, listen, you'll learn something new in this latest episode of Collaborative Corner.
Optometrists are the primary eye care professionals. We see 90% of all contact lens exams. We see 85% of all just basic comprehensive eye exams. Now, what's interesting and what's also kind of sad is that the US prevalence of keratoconus is about 1 in, I'd say, 2,000. Outside the United States, it's actually like the Netherlands, for example, there was a study that showed that it's like 1 in 375. Now, what's even more important is that the challenge for us to be able to tell if somebody has keratoconus kind of falls upon our clinical acumen. It falls on us to look for, topographical changes or look at hereditary, because this is a disease that's both a dystrophy and also a degeneration. Is it the chicken or the egg? Which comes first? Do they have these matrix changes in the cornea? Is it the rubbing of the eye that causes it to soften, or is it just the genetic predisposition? In 2021, we now have the ability to be able to discern whether or not our... Wait, hold on, shh. Do you hear that? The genes are talking, and Avellino Labs is listening. That's right. Avellino Labs out of Menlo Park now has a genetic test that we can use in our office. It's called the Avogen. And what's nice about the Avogen is that it's a simple swab test we can do on our patients. We send it out to their lab, they'll come back to us and the patient with a report. They have counselors on hand to be able to talk about this. What this genetic test is going to be able to do is give us early diagnosis, give us right diagnosis. Because with 75 different genes for keratoconus and 1,000 different variants, or 70 different TGFBI mutations giving us corneal dystrophy awareness, we now have the opportunity to basically tell our patients, look, this is where you're headed. Now, from a cataract and refractive surgery option, it really means we can guide our patients into better options, if you will. Now, something that's really staggering is that if you step back and think about it, most of our patients who have keratoconus, are basically 1 in 5 are going to end up having to have a corneal transplant. And I think a large reason why that's happening, and of that corneal transplant, the numbers are kind of crazy. It's like 73% of those grafts will fail within 20 years, and then 96% of those grafts are gonna fail within 30 years. Moreover, our keratoconic patients are spending on average in a lifetime about $43,700. Yeah, we're gonna round it up to a simple number like $43,759. By doing a test like the Avogen, by basically telling our patients, let's find out early. Let's learn, let's educate. We can then guide them into newer options, newer procedures. In fact, there is a newer procedure. I mean, there's something that we can do. We can actually talk to our patients about, wait, hold on, I'm still listening, I think. I feel like the genes are talking, or it's something in my head talking. I don't know. Hold on, something's talking. Did you guys hear it? Okay, I'm a little scared now. I'm scared. I'm scared. Cross-linking is everywhere. I mean, we see it in everything and almost a lot of things we do, whether it be like our Camelback water bottles, or whether it be when you go into get a manicure and they're like, hey, would you like to come in and have gel nail? Okay, only $5 more? Yeah, that's cross-linking. Cross-linking is what turns, cowhide into leather, or turns our skin into leather, which we've seen quite a lot. It's as safe as something to use when you're basically looking at the resin that hardens on teeth. In fact, Theo Seiler, when he first invented this, he actually went and saw his dentist and he asked him, "Was are you doing? That's my best Austrian accent." And that's when he came up with the idea that we could actually use cross-linking on the cornea. I mean, it's one of those things where it's just very simple, very easy, and we see it all the time. In fact, one of the places where we actually see it the most is like when we're making our jello pudding in the, is it too soon? Too soon for that? I mean, this thing just happens like cross-linked. Put a hat on to try to like get the genes to stop talking, so I hopefully won't hear them. But one of the absolute important things that we have to do is to diagnose early. In fact, there's been a couple studies that showed while we waited for patients that had keratoconus, during COVID, for example, there was 2 studies. There was a study done by Shaw in the UK. He found 46 progressive keratoconic patients worsened with wait time made longer by the COVID pandemic. In fact, the typical average wait time was about 182 plus or minus 65 days, and the COVID restrictions added 3 extra months in the UK. And they found the worsening keratometric indices, and patients lost nearly 1 line of visual acuity. There was another study in New Zealand where they found that 39.6% of 38 patients of 96 eyes worsened over 153 days plus or minus 101 days. Now, worsen, waiting, we do these genetic tests, and we now have the first FDA-approved epi-off option, which is cross-linking. Glaukos is the only FDA-approved system. This is the iLink system, and this is the only FDA-approved opportunity for our patients to stop or halt the progression of these really just horrible diseases. Now, I've always kind of looked at optometry as being the providers, the gatekeepers, the front line. We're master blaster, especially when it comes to things like keratoconus, because we're the ones fitting the context. But imagine, if you will, an opportunity where you can refer a patient to a doctor who is working with the iLink system. Okay, they're using the Photrexa viscous, the riboflavin with the 20% dextrin, or they're using the Photrexa solution to basically, if they need to kind of create a thicker cornea. In order to do the procedure, you have to have at least a minimum of about 400 microns, and that can be artificially managed to get it to that area. But I would tell you, don't wait until your patient starts thinning and progressing, especially if you're able to diagnose these patients a little bit earlier, because activating that riboflavin, especially in a FDA-approved process, and creating these crosslinks means that we can slow down the progression, or even in large cases, halt the progression of this disease state. When I start thinking about collaborating with doctors and surgeons, to me, isn't it great if you can collaborate with optometry within ourselves for those that are fitting scleral lenses, or those of us, wait, slow down, those of us, not me. I know less about contact lenses than like a first-year optometry student. If you're watching this, that's true. But for I gotta stop saying that. For optometrists that are fitting sclerals or these hybrids or fitting the duets, and I just can keep going because I have no idea what I'm talking about, but you guys know what I'm talking about. Then referring within those practices, but then also collaborating with surgery centers, especially ones that are using the iLink system. Okay, go online, find doctors that are doing this, and find out what you need to do to get your patients there. Because what's phenomenal right now is that this is an FDA approved, but there's also insurances that are covering this for progressive keratoconic patients. And so we need to be able to find optometrists to collaborate with us for surgery centers that are doing this, because they have to note and we have to see progression of this disease state. In fact, if you go to the Glaukos website, you can find maybe a form where it shows you that you can print out, where you can follow these indices. But better yet, do something for your patient right now. Okay, stop right now and go into your practice and think, okay, I'm gonna keep a running tab of what the Ks are, what the refraction is, looking at astigmatism, whether or not it's gone up $1.50 or a little bit less. And then calling whoever is in your area that's utilizing this FDA approved system so that you can collaborate with them. I mean, to me, there's no reason why we shouldn't be incorporating crosslinking. I mean, we're talking cross-linking. We're not talking practice. We're talking cross-linking. You do it, I mean, come on. I still feel like I'm hearing the genes are talking. I still feel that, even with the beanie on. So I think I need to take care of that. But this has been another episode of Collaborative Corner, and we'll see you guys all next time, okay? Yeah, cross-linking.
What are you doing?
I'm making some jello.
No, stop it, right now.
Don't eat the jello.
No, you know what I'm talking about. No more.